all of you. So today we are going to discuss a very basic and very important things for today's session. That is the understanding the different types of diabetes. So there are many types of diabetes, but I will be focusing basically on the most important types. So diabetes mellitus may be defined as a metabolic disorder characterized by persistent hyperglycemia due to either insulin inaction, that is resistance, and or relative or absolute insulin deficiency. As per the idea of Atlas, globally there are around 537 million people who are affected with type 2 diabetes mellitus, and this is expected to increase to 643 million by 2030 and 783 million by 2045 if corrective steps are not taken. As per the ICMR India Diabetes study, India is already home of more than 100 million diabetes patients, and three-fourths of all these diabetes patients live in the low and middle income countries like India. Close to 50% of adults with diabetes are still undiagnosed, and almost 80% of these live in low and middle income countries. 540 million adults have impaired glucose tolerance, that is pre-diabetes, which puts them at risk of developing type 2 diabetes mellitus if we fail to uh, introduce the lifestyle changes among those people. So this is the normal physiology of glucose metabolism in normal healthy individuals. When people eat, it increases their blood sugar level, which is sensed by the beta cell of the pancreas, which in turn secretes insulin, which is utilizes the insulin, the glucose by different cells. Liver uses insulin to store the glucose in the form of glycogen, and when we fast, this glycogen is broken down to glucose by the another hormone secreted by the alpha cells of pancreas, that is glucagon. So this is the normal pathophysiology, normal homeostasis of blood glucose regulation in normal individual. So before going into the diabetes, uh, I would like to discuss a very important entity, that is pre-diabetes, that is very important in the pathophysiological pathway of type 2 diabetes mellitus. So it is a potentially reversible condition, and the diagnosis can be made as per the ADA guideline if your fasting plasma glucose is either between 100 to 125 milligram per deciliter. Post
Oh,
fasting plasma glucose is 100 to 125. Postprandial plasma glucose is 140 to 199 milligram per deciliter, or HbA1c is between 5.7 to 6.4. So if you have these three parameters or any one of them, you are going to have type 2 diabetes, which is a potentially reversible condition. And at this point, we need to change our lifestyle. We need to change our diet. We need to increase our physical activity. And by adopting a healthy lifestyle, we can stop the progression of pre-diabetes to the front type 2 diabetes mellitus. So, what are the symptoms of diabetes mellitus? It will be common across the different types of diabetes, and these are blurry vision, dizziness, always hungry, tingling, increased thirst, fatigue, vomiting, weight loss, frequent urination, headache. And out of all these symptoms, the classical symptom of diabetes mellitus are polydipsia, that is frequent thirst, polyphagia, that is frequent hunger, and polyuria, that is frequent urination. But these classical symptoms of diabetes mellitus does not appear unless and until you are having a very high blood sugar level. One important other symptom of the diabetes mellitus is genital infections and shoulder pain, because 50% of the frozen shoulder patients may present with diabetes mellitus. And most important symptom of diabetes mellitus is that it is asymptomatic in more than 50% of patients. So, because at the lower blood glucose level, there are hardly any symptoms, especially if it is newly diagnosed. In long-standing cases, we may get some symptoms at even lower blood glucose level, but the classical symptom of diabetes mellitus, that is polyuria, polydipsia, and polyphagia, are rarely present altogether in a single patient unless and until patient is having a very hyperglycemic state. So, diagnosis of diabetes mellitus in non-pregnant individuals, as per the ADA guideline, if fasting is more than equal to 126 milligram per deciliter, or 2-hour plasma glucose is more than equal to 200 milligram per deciliter during an OGTT, or in a patient with classical symptoms of hyperglycemia, that is polyuria, polydipsia, and polyphagia, a random plasma glucose of more than equal to 200 milligram per deciliter, or HbA1c equal to more than 6.5. In the absence of unequivocal hyperglycemia, results should be confirmed by repeat testing. So different types of diabetes. There are lots of classification system available in the books, but for the sake of simplicity, I have divided uh, in this classification in four types. That is type 2 diabetes, type 1 diabetes, gestational diabetes, and other specific types of diabetes. And we will discuss all these one by one. So type 2 diabetes mellitus represents more than 90% of the cases globally. It usually develops after 30 to 40 years of age, but due to change in lifestyle, even younger people are getting type 2 diabetes mellitus, which is a point of concern. In my clinic, I even have a patient who is only 15 years of age and she is having type 2 diabetes mellitus. The predominant pathophysiology is insulin resistance, and other pathophysiological changes are increased hepatic glucose production, abnormal fat metabolism, and impaired insulin production. Type 2 diabetes mellitus is a progressive disease as insulin production decreases over time due to progressive loss in beta cell function, and many type 2 diabetes patients may need insulin therapy for glycemic control in due course of time, especially those who are having long-standing diabetes. Obesity is present in more than 80% of the patients, especially the visceral obesity, which is a very important risk factor of developing type 2 diabetes mellitus. This is the pathophysiology of type 2 diabetes mellitus, not only the inadequate beta cell function, also the other organs play a crucial role, that is the fat cells, kidney, brain, gut, pancreas, muscles, liver, every organ has got something to add into the pathophysiology of type 2 diabetes mellitus. So that's why, with the understanding of this pathophysiological mechanism, we are having multiple molecules for the treatment of type 2 diabetes mellitus, which target one or more of these pathways and uh, acts to the control of glycemia. So, what are the risk factors for the type 2 diabetes mellitus? It is modifiable, another is non-modifiable. Non-modifiable risk factors are ethnicity, first degree relative with diabetes, and increasing age. Ethnicity, particularly the Southeast Asian population, are on increased risk of developing type 2 diabetes mellitus at a decade earlier than their Western counterparts. Modifiable risk factor includes unhealthy diet, physical inactivity, obesity, women who delivered a big baby, decreased SDL and or increased triglyceride level, hypertension or history of CVD. The obesity classification for Southeast Asian population, the BMI cutoff has been lower because of the uh, higher fat mass at a lower BMI, and the obesity overweight classification for the Southeast Asian population is BMI more than equal to 23, as compared to the Western counterparts where the overweight is BMI more than equal to 25. So type 1 diabetes mellitus, it is an autoimmune diabetes which results from the autoimmune destruction of the beta cell, and type 1 usually presents before 30 years of age and most common among children and adolescents. Type 1 diabetes mellitus results from the autoimmune beta cell destruction, and most of the individuals, except few like the African American and the Asian lineage, which may not show the autoantibody titer, most of the type 1 patients will show autoantibodies against their uh, beta cells. So islet cell antibodies are a composite of several different antibodies directed at pancreatic islet molecules such as GAD, insulin, IA2, ICF12, zinc transporter 8, and serve as a marker of the autoimmune process of T1DM. And most commonly investigated and commercially available antibody in the market is estimation of the anti-GAD65 antibody and ICA, ICA, which is present in more than 85% of the new onset type 1 diabetes mellitus patients. So this is the comparison with between the type 1 diabetes and type 2 diabetes. Clinically, type 1 are usually either normal range BMI or underweight. While in type 2 diabetes, it is overweight or obese. In type 1, cause of the disease is insulin deficiency, damage.
I
In
would
the
request everyone to mute themselves, please.
so
Please mute
predominant
yourselves.
insulin resistance, in presence of autoantibodies in the type 1 diabetes, but these are absent in type 2 diabetes mellitus patients. Disease onset is usually acute with accompanying diabetic ketoacidosis in type 1 diabetes, and most of the time, adolescent or kid land in the emergency department with diabetic coma. Usually, type 2 DM highlight
orang
on
bodohnya.
best
Mana
some of
cake yang kami bisa masyur minne sa dimitte bawalate.
type 2 diabetes mellitus, initially metformin and other orally administered medication. In some cases,
Lintas.
it requires insulin. The occurrence of the disease depends on the patient lifestyle. In type 1 diabetes mellitus, no, they develop because of the autoimmune destruction of the beta cell which secretes insulin. In type 2 diabetes mellitus, it is predominantly lifestyle related. But remember, lifestyle management is very important for the management of good glycemic control of both the type of diabetes mellitus. So before going to the other type of diabetes mellitus, we are having a separate entity that is LADA, which the American Diabetes Association lists LADA as the type 1 DM that evolves more slowly than the classic disease and does not recognize it as a specific type of diabetes mellitus. The World Health Organization defines LADA as a slowly evolving immune-related diabetes. This LADA is actually behave like type 2 diabetes mellitus to begin with, but later on, when the autoimmune destruction of the beta cell is complete, it changes to the type 1. So the Immunology for Diabetes Society has specified three criteria for the diagnosis of LADA. That is age greater than 30 years, positive autoantibodies to the islet beta cell, insulin dependence for at least uh, the initial 6 months after initial diagnosis. But actually, this criteria is debatable because the insulin initiation is clinician dependent. But we have some criteria as per the Immunology for Diabetes Society. Blood is immunologically similar to type 1 diabetes, as antibodies to islet beta cell are present. But at lower titers, the immune destruction progress at much slower rate than compared to classical type 1 diabetes. Most of these patients present with hyperglycemia that is not as dramatic as type 1 DM and is misdiagnosed and managed as type 2 DM at least early in the uh, uh, disease. So, hyperglycemia in pregnancy comprises pre-gestational diabetes mellitus, gestational diabetes mellitus, and diabetes in pregnancy. And more than 80% of cases of hyperglycemia in pregnancy are due to the gestational diabetes mellitus, while 10.6% were the result of diabetes detected prior to pregnancy and 9% due to the diabetes diagnosed first time in the pregnancy. These are some regional difference in the prevalence of HIV, with the Southeast Asian region having the highest age-adjusted comparative prevalence, that is 28% as the IDF 10th atlas. Glucose intolerance developing during pregnancy is classified as gestational diabetes. Insulin resistance is related to the metabolic changes of the late pregnancy, and the increased insulin requirement may lead to impaired glucose tolerance or diabetes. Most women revert to normal glucose tolerance postpartum but have a substantial risk, that is 35 to 60%, of developing diabetes mellitus in the next 10 to 20 years of their life. So, causes, there is increased insulin resistance. These pregnancy hormones are at their highest level at about 24 to 28 weeks of pregnancy. So, the maximum chance of getting a diagnosis of GDM is during the second trimester. Risk factors for the GDM are ethnicity, obesity, especially the central obesity, past history of large baby delivery, and history of diabetes among first degree relatives. So diagnosis of GDM, we have there are multiple criteria, but I will be focusing only on the two most important criteria. One is the ADA, that is American Diabetes Association criteria. The first one is the single step, that is one step protocol, where OGTT is performed with 75 gram glucose in fasting state, and diagnosis of GDM should be made if fasting is more than equal to 92 milligram per deciliter, or 1 hour more than equal to 180 milligram per deciliter, or 2 hours is more than equal to 153 milligram per deciliter. We have another two-step protocol for the GDM diagnosis as per the ADA. In first step, OGTT with 50 gram glucose irrespective of the last meal, and if 1 hour prandial glucose is more than equal to 150 or 40 milligram per deciliter, we subject our client to a second glucose challenge stage, that is the with 100 gram glucose in fasting state. Remember, the first step with the 50 gram was irrespective of the last meal, but the second step with 100 gram is in the fasting state, and the diagnosis of GDM is made if fasting is more than equal to 95 milligram per deciliter, 1 hour PG is greater than equal to 180 milligram per deciliter, or 2 hours is more than equal to 155 milligram per deciliter, or 3 hour post plasma glucose is more than equal to 140 milligram per deciliter. In India, it is very difficult to get women in fasting state. So we have a Commonly used another criteria, that is the DIPSI guideline, diabetes in pregnancy study group in India, that is OGTT with the 75 gram glucose is done irrespective of the last meal. We do not need any fasting state to adopt the DIPSI criteria. And diagnosis of GDM should be made if plasma glucose level at 2 hours greater than is equal to greater than equal to 140 milligram per deciliter. And the treatment of GDM as per the latest area guideline is MLT as per plus insulin. So other types of diabetes, there are multiple. I will be focusing on few important ones. There may be genetic defects in insulin secretion, maybe genetic defects in insulin action, maybe disease of the exocrine pancreas, disease endocrinopathies, drug or chemical induced leading to the beta cell destruction, infections, uncommon forms of immune mediated diabetes, other genetic syndromes sometimes associated with the diabetes. So let's deal it one by one. So uh, there are more than 12 or 14 modies diagnosed till date, but I am focusing on the important one. Modi 1, 2, 3, 4, 5, 6. So in Modi 1, Modi 3, and Modi 5, we have HNF4 alpha, HNF1 alpha, and HNF1 beta gene mutation respectively. In Modi 1, the main mechanism is defective beta cell signaling in response to the glucose and insulin, impaired insulin secretion. Treatment involves sulfonylurea plus minus insulin. In Modi 2, there is defect in the glucokinase gene, which alters the set point for the insulin secretion, and the treatment is usually insulin. In Modi 3, there is defective transport and metabolism of glucose, and the treatment is usually sulfonylurea. In Modi 4, there is mutation in the insulin promoter factor 1, which regulates the pancreatic development insulin gene transcription, and treatment may range from sulfonylurea to frank insulin use. That depends on the involvement of pancreas. Modified, again, the mutation in the HNF1 beta gene, which leads to defective insulin secretion and increased hepatic insulin resistance, and the treatment is insulin. In Modi 6, there is neurodifferentiation 1 gene, D1 gene, primary defect in insulin secretion, and the treatment is insulin. Remember, dear friends, the diagnosis of diabetes mellitus is based on the blood sugar level and HbA1c level. But the type of diabetes mellitus should be diagnosed based on different antibody or genetic profiling should be done. Sometimes for the diagnosis of type 1 diabetes, we test for the insulin, but most of the time we go for the C-peptide estimation. And if the C-peptide level is very low, we diagnose it as a case of type 1, especially in newly diagnosed diabetes. But in long standing, we may go for the autoantibody testing because type 2 diabetes sometimes presents with low C-peptide level. So, syndrome of insulin resistance, that is type A insulin resistance, Labrationism, RM syndrome, lipodystrophy syndrome, all these syndromes are actually syndromes characterized by the severe insulin resistance. In type A insulin resistance, it is a syndrome characterized by hyperinsulinemia, acanthosis nigricans, and signs of hyperandrogenism in females. In Labrationism, it is a congenital form of extreme insulin resistance that causes severe growth retardation. People with these conditions have some small bulging eyes, thick lips, and upturned nostrils. RM syndrome, affected people are usually small and experiences failure to thrive as infants. Other features include lack of fatty tissue, muscle wasting, dental abnormalities, and excessive body hair growth. Lipodystrophy syndrome, it is a group of rare disorders that causes variable loss of body fat. The loss of body fat can affect the entire body, certain body regions, or a small area under the skin. Other disease of the pancreas, especially the FCPD, fibrocalculous pancreatic diabetes, quite common in the southern part of the India, which develops because of the stone in the pancreas, which ultimately affects the insulin secretion from the beta cell, due to the fatty infiltration of pancreas. Other disease, cystic fibrosis, chronic pancreatitis, may lead to the development of diabetes mellitus. Endocrinopathies, common ones are Cushing syndrome, hyperthyroidism, acromegaly. Cushing syndrome may be, sorry, Cushing syndrome may be because of the external steroid treatment leading to the hyperglycemia and secondary diabetes. Drug or chemical induced like glucocorticoids, nicotinic acid, diazoxide. Diazoxide is one molecule which destroys the beta cell. Infections, that is congenital rubella, cytomegalovirus, and Coxsackie infections. Uncommon forms of immune-mediated diabetes, that is Steve-Person syndrome, anti-insulin receptor antibodies. Other genetic syndromes sometimes associated with the diabetes, that is Down syndrome, Klinefelter syndrome, Turner syndrome, and there are many more. Uh, but remember, the most common type, that is type 2 diabetes, represents more than 90% of the diabetes mellitus patients across the globe. Then the type 1 diabetes, the gestational diabetes, and rest, that is less than 2% cases belongs to these other types of diabetes. So we need to focus on each and every type of diabetes mellitus, because correct diagnosis of type of diabetes is very important, and most common error happens between the distinction between type 1 and type 2 diabetes. I, uh, 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 I have come across many patients who are getting treatment with the type 2 diabetes mellitus and having HbA1c 11, 12, and when I go for the investigation, it actually turns out to be a type 1 diabetes, and patient does good with the insulin, even with the low dose of insulin. So, correct identification of type of diabetes is important for the management of patients. Thank you from my side. Back to the organizing team.